Alright, hello everybody. Welcome back. We're going to be focusing on the respiratory system for this video. So let's go ahead and get right into it. Now, I often don't really like some of these slides where they go over the primary functions of each system because personally I kind of see the more that you study medicine, the more interrelated a lot of these guys are. Gas exchange we'll definitely be talking about because we're going to talk about how CO2 and O2 are going to be exchanging those gas molecules back and forth. Our pH regulation, this is actually going to be a huge component to today's video because I really want to emphasize the importance of our bicarbonate buffer system. Voice production, we'll talk a little bit about vocal cords, where they're housed and how they work in general. Olfaction, this kind of just comes with our sense of smell here. Protection against pathogens. We are going to talk a little bit about how we have some protection against pathogens with regards to the respiratory system, but keep an eye out for the lymphatic system because the lymphatic system is going to be kind of the emphasis on going over this kind of material. And then blood pressure regulation. So blood pressure regulation is actually not something that we cover during the respiratory system. Usually we'll actually get into that a little bit more when we talk about the urinary system. So we'll save that for another time as well. Now, in general, there's two different ways that we can divide the respiratory system. First, there's the anatomical way. Here, we're actually looking at the anatomical difference. There's an upper and a lower respiratory system, and usually we use the larynx as the kind of point of contact for when we're describing the upper respiratory system versus the lower respiratory system. The other way we can actually divide the respiratory system is by a physiological difference into a conducting zone and into a respiratory zone. The conducting zone is pretty much the entire traveling that the air does throughout the entire respiratory system until it gets to the final point of, respiration where gas exchange is actually going to be occurring, and that would be known as the respiratory zone. So taking a look at our upper respiratory system, everything is obviously going to start in the nose and the nasal cavity. We do have some of our sinuses, some of our paranasal sinuses that we'll be bringing up. We're going to kind of move on into the pharynx. So the pharynx is just the general term that kind of describes the combination of the nasal cavity as well as the oral cavity together. Working its way into the lower respiratory system, we have the larynx, which starts with an L, and so does lower. So that's an easy way to remember that the lower respiratory system is at the larynx. The larynx is eventually going to morph into what is known as our trachea. Now, the trachea is the general windpipe, I guess, and more like a common term. It's going to be our general windpipe that's going to be traveling down the length of our neck into our chest cavity. Once it gets to about our chest cavity, it's going to split into a left and right bronchus so that it can actually enter the left and right lungs respectively. So we can see bronchus. We're gonna get into a little bit more detail about the different types of bronchus that we have as well. And taking a look down here, we have bronchioles. So oles is just kind of referring to a smaller branching of the bronchus. So all of these tiny little branches coming off, these would all be the bronchioles. And this can actually divide several times. The bronchioles can go up to almost 26 generations of just division, trying to get to the lowest level. And the lowest level of our lungs is actually going to be the alveoli. So the alveoli are these little bundles of grapes that you see. Each of these, circles is pretty much its own cell. It's covered in simple squamous epithelium, and this is what's going to be allowing for that gas exchange to occur at the smallest, most microscopic level is the alveoli. So here we kind of talked about the physiological difference between the respiratory tract. There's the conducting portion and the respiratory portion. We'll kind of move on. These definitions are pretty solid. Alright, so identifying some of the organs of the upper respiratory system. Now, first off, the external nares is just generally going to refer to your nasal cavity, how it's actually going to be entering the nasal cavity. But you can also see inside of the nasal cavity, we have these bony projections. Now, hopefully, this is not new material to you. This should be a little bit of review. But within the nasal cavity, we have these concha, these bony projections that stick into the nasal cavity. There's a superior, a middle, and an inferior nasal concha. Now, unfortunately, on the image that we see here, this blue guy, this would be inferior, and middle would be the green one. However, we can almost never see the superior nasal concha. You definitely won't be able to see it on the cadavers. I looked around as much as I could, but I was only able to see the middle and inferior, so that's what we'll primarily focus on. And the whole reason why we have these nasal concha in the first place is because these nasal concha actually cause turbulence to the air as it enters the nasal cavity. What this is going to do is going to warm and humidify the air so that it's not this like raw and cold air that's kind of entering your respiratory system, but rather it's warmed and humidified, and it's already been filtered out for a variety of different pathogens too. The meatus generally refers to a groove. So the superior, middle, and inferior nasal meatus are just going to be the small individual pathways that are going to be following the concha. So underneath the inferior nasal concha would be a small groove in here. This would be the inferior nasal meatus. The middle nasal meatus would be right underneath the middle nasal concha, so we can actually probably see it a little bit easier here. So yeah, if we have our concha here, our meatus is going to be the small groove in between, kind of like that. And then as for our paranasal sinuses, we have 4 paranasal sinuses that we should keep in mind as we work our way through the video. It's going to be our frontal bone, ethmoid. Really struggling with PowerPoint here to just leave my drawings alone, but looks like that's not going to happen. Our sphenoid, as well as the maxilla. So we previously learned last week when we were talking about veins, we learned that a sinus just kind of refers to like a big, hollow, and open space. What our paranasal sinuses are, it's these 4 bones that all contain a big, hollow, open space. And the reason why they actually contain this big and hollow and open space is actually for 2 reasons. One, we don't want the bone to be too dense in order to maintain our posture with relatively little effort. We don't want our head to be too heavy to pick up all the time. And number 2, inside of these paranasal sinuses is actually where we get some of our mucus being produced and actually secreted to actually help us capture any pathogens that are trying to enter our system through the respiratory system. So all the mucus that we kind of use to kind of protect ourselves is actually being produced from the paranasal sinuses. Taking a look at the nose, we have the external nares. That's just referring to your nostrils again. Nasal hairs, all you really have to know about nasal hairs is that they act as the first particle filtration system. So basically just imagine it kind of swatting away all these particles. Here we have the nasal septum. So septum just translates from the Latin to meaning wall. So the nasal septum is the wall that's going to divide the nasal cavity into a left and right portion. The superior portion of the nasal cavity is the olfactory region. This is just where our sense of smell is once again. You should remember from cranial nerve 1, it's our olfactory nerve, right? Mucus secretions, we kind of talked a little bit about that already. Let's kind of keep going. Yep, we talked a little bit about, warming and humidifying incoming air, trapping particles. Alright, now that we're moved on. So, what exactly divides our nasal cavity and our oral cavity? Well, I'll tell you, it's actually going to be a combination of this hard palate and soft palate. Now the hard palate is going to be a more anterior position. This is actually going to be our palatine bone right over here. We can actually see this in the bifurcated cadaver in the classroom too. So it's actually pretty cool. We can see the hard palate named after because it's made of bone. And the soft palate is going to be this small bit of tissue on the posterior aspect that's also continuing to help separate our nasal cavity and our oral cavity. Now previously we talked about the pharynx. Right, the pharynx is the joint cavity of where our nasal and oral cavities are kind of coming together. But there's actually 3 different sections of the pharynx. There's going to be the nasopharynx, oropharynx, and laryngopharynx. Now it's only the only thing we really need to focus on here is just a matter of working our way from superior to inferior and getting that order correct. So if we have the term like nasal is referring to nose, right? We have the term oro, that's going to be referring to mouth. So as long as we remember that our nose is superior to our mouth, we'll also remember that the nasopharynx is going to be superior to the oropharynx. And then all the way at the very bottom, closest to our larynx, will be the laryngopharynx. And we'll get into a little bit more about the larynx in a minute. We also have our auditory tubes. So our auditory tubes are going to be located right over here. It's also referred to as the eustachian tube. This tube is going to connect our pharynx to the middle ear. And the reason why we want this to occur is because we want to be able to equalize out the pressure. Take in mind, if you have ever been on a road trip where there's a lot of change in elevation, you're going up and down these mountains, and you cover your nose and you blow out, right? You're actually inflating these auditory tubes or eustachian tubes, and you're actually equalizing out the pressure in your head. It's pretty cool. Now for the larynx. The larynx is primarily composed of two bits of hyaline cartilage, the thyroid cartilage and the cricoid cartilage. Now, the thyroid cartilage, right, we can actually see is pretty relatively close to our thyroid gland. So it's kind of an easy thing to remember. Okay, we got thyroid gland, and we also have our thyroid cartilage. Our thyroid cartilage is going to be the initial start to our lower respiratory system. It's also going to be the introduction to our trachea. So here we have our thyroid cartilage. Our thyroid cartilage also holds the vocal folds or vocal cords. So the vocal cords, the organ of production of speech, that's going to be found within our thyroid cartilage. It's going to be protected in there. The cricoid cartilage is going to be the first complete circle of our trachea. So the cricoid cartilage is actually a piece of hyaline cartilage that wraps its entire length. Oh, discard. No, shoot. Okay. Hold on. Let me just go ahead and get back to where we were. Just past it. Nope. Okay, perfect. Sorry about that. All right. Anyways, cricoid cartilage is going to be, the first complete ring around the trachea. And then as we kind of work our way down, our trachea only has tracheal cartilages that are going to be C-shaped. And we'll get into that in just a little bit. Now, taking a look, part of our larynx, we have what is known as the epiglottis. Now, generally, glottis is going to be referring to the throat of the respiratory system right over here. The epiglottis is going to be found above that. So this guy right here, this is our epiglottis. Now, how this epiglottis works is actually going to be kind of like a trapdoor. Now, its natural state of being is going to be open. It's going to be open and it's going to be up. The reason being is because most of the time, all we're doing is breathing, right? We're mostly breathing and talking throughout our day. However, if we ever have the need to, swallow some food or anything like that, as we kind of initiate the swallowing mechanism, this trap door is going to come down and close. So if we have this trap door down and closed, the food has no choice but to travel down the backside, which is going to lead down the esophagus instead. And that's going to go into our digestive system. So if you have ever been, out eating at a restaurant or something, and you said, you started choking on a piece of food, you're like, oh man, it went down the wrong pipe, right? It's a pretty common saying. That's actually a pretty straightforward analogy. That analogy actually is describing exactly what happened. It went down your trachea instead of your esophagus by mistake. Yep, sounds good. Wonderful. Talked about that. Great. Oh yeah, one other thing, on the thyroid cartilage itself, one thing to heads up to, all respiratory cartilage is pretty much just about always going to be hyaline cartilage, just a heads up, so that shouldn't be too much of a surprise. But on the anterior surface of the thyroid cartilage, we have our Adam's apple. However, we want to use the more anatomically appropriate name. It's going to be known as the laryngeal prominence. Laryngeal because it's found in the larynx, prominence because it's very, very large. Cricoid cartilage, yep. Epiglottis, wonderful. Alright, so taking a look at this, what we can actually identify here is our vocal fold, right? This is our true vocal cord. And the ventricular fold, which is going to be our false vocal cords. So we actually do have two pairs of vocal cords. We have a true set and we have a false set. The true vocal cords are actually what are going to be producing noise and sound. The false vocal cords are ventricular fold. This is just a piece of tissue that actually acts to help protect our vocal cords. Here you can actually see a better example of it. These two white ligamentous lines in the middle, those are going to be our true vocal cords. The pink soft area on the outside, this is going to be the false vocal cords. Alright, so moving our way over, we have the larynx. Here, once again, is our thyroid cartilage. the first ring of the trachea is going to be our cricoid cartilage, and then we're kind of moving on to the actual trachea. So for the actual trachea, we can actually see this C-shaped ring. Now, there's going to be a few different reasons why we have this C-shaped ring. One of the primary purposes is the fact that we don't want our trachea to collapse. If our epiglottis were to close and we did not have these C-shaped tracheal cartilages, our respiratory system would actually collapse because of the lack of pressure that we don't have anymore if our epiglottis closed. So that's the one thing that our cartilage rings, they're going to be preventing the trachea from collapse. Two, the reason why they're C-shaped and not complete is because we don't want to squish this esophagus, and the posterior side, what's actually in contact with our esophagus, is going to be known as the trachealis muscle. And this trachealis muscle actually controls our bronchoconstriction and our bronchodilation. So basically how big our bronchioles can go up and down. Now, as we follow the trachea down, we're eventually going to get to about this level. This is going to occur about the fourth vertebral level, or fourth thoracic vertebral level, about T4. And what's going to happen here is that the trachea is going to split into the carina. Now, the carina, right here, is just pretty much describing the splitting of the trachea into a left and right primary bronchi. So we get the term primary bronchi. Primary bronchi are eventually going to evolve into secondary bronchi, and then to tertiary bronchi, and then eventually divide into our bronchioles. But this is not where the adventure stops. Our bronchioles are actually going to go all the way down to become terminal bronchioles. Now, if we get the name terminal, terminal means like finale, or like the final, or the end, right? Now, our terminal bronchioles are going to be the end of the conducting zone, but actually they're going to also be the beginning to the respiratory zone, which is where our respiratory bronchioles kind of stick in. So by the time we get to the respiratory bronchioles, this is where gas exchange is actually going to be starting, right? It doesn't always end here, but it's at least going to start at the respiratory bronchioles, because by this point, our cells are thin enough that gas can start to switch back and forth. Our respiratory bronchioles are just going to follow the order of alveolar duct, alveolar sac, and alveoli itself. This entire section right over here is pretty much going to be the entire respiratory zone. Mediastinum, 15, 20, yep, sounds good, wonderful. Alright, so we have a right and left primary bronchi. Each one is going to go to a particular lung. The right primary bronchus is actually going to be larger in diameter than the left, and it's going to descend at a more vertical angle. So if we have, our right lung and our left lung, and we got the trachea coming down, primary bronchus is going to be a little bit wider, a little bit more thick, and then the left is going to go at a more situated angle. So this kind of right side right here, the reason why I'm explaining this is because this is actually clinically relevant. If a child or somebody got something like, like a Lego, like they swallowed a Lego by accident, swallowed some change by accident, and it got stuck in the respiratory pathway, because the right primary bronchus is going to be larger and it's going to be more vertical, the path of the object is most likely to travel down and enter the right lung. So it's just relatively clinically important to kind of understand that concept, that if something's getting choked on and swallowed, it's more than likely going to end up in the right lung. And I'll kind of explain why the right primary bronchus has a steeper angle and a larger in diameter when we go over the actual features of the lung. So let's see if I can find our lung shape. I'm gonna do this. We are gonna get a new slide. Let's just kind of delete all these. Perfect. And now we're gonna kind of draw out our lungs ourselves. Hopefully the pen works with me. So first off, we're gonna have our right lung, right? Something like that. And then we're gonna have our left lung. Our left lung is gonna be slightly smaller. It's gonna look like somebody actually took a bite out of our left lung. Oh, well, I didn't make the bite that big, but you can kind of tell there's like a small indentation here. So for our right and our left lung, we actually have our right and our left lung divided into what are known as lobes. Now the reason why we want several lobes per lung is because if one of the lobes is compromised, we actually have a backup kind of system to breathe into in the meantime. So what we're going to do with both lungs, we're going to draw this initial fissure. It's going to kind of cut the body into left and right, kind of like that. Oh my. Now, since the right lung is a tad bit bigger, we're actually going to cut this in half once more. Kind of like that. Now, the name of the fissure, right? The name of this divide is actually going to be known as the oblique fissure. Oh, that's a really bad spelling, but it's supposed to be named after the oblique fissure. And it's actually going to divide our left lung. I'll put a left or an L up here and a right for right. It's actually going to divide our left lung into a superior and an inferior lobe. Now the same thing is going to be happening over to our right lung. We have an oblique fissure. We got our horizontal fissure because we got that one extra one that the left one does not have. Alright, you get the idea of me trying to spell horizontal. And then we have three different lobes. We have a superior lobe of the right lung, we have an inferior lobe of the right lung, and we're going to have a middle lobe. Oh man. Okay. One other thing that we want to do to properly orientate ourselves with the lung is we want to make sure that we identify the apex and the base. So the base is going to be the larger, flatter component. It's always going to be on the inferior side of the lung. And then we have the apex. So the apex is going to be the top portion of the lung where it comes to a point. So this would be apex. Now, taking a look at the left lung, we'll notice that, there's a small indentation here. This small indentation is actually going to be known as the cardiac notch. Now, for those of you who don't know, our heart does not sit asymmetrically in the chest, right? Our heart actually points and brushes into the left side a lot. So in order to kind of make up for this, this heart, this angry roommate kind of pushing in on the left lung has to kind of compromise itself so that the heart can fit inside. So inside this cardiac notch, this is pretty much the impression that the heart has by pushing into the left lung. This is also why the right lung is going to be much larger, because the left lung has to deal with, dealing with adequate room for the heart, whereas the right lung doesn't really have that issue. So that's also why when we have our bronchi coming down, it's going to be more steep, and then this one's going to be more horizontal. Now, we previously discussed that the trachea comes down to the point of the carina, and it's going to split into a primary bronchi. These primary bronchi are going to split once more, and they're going to split into the appropriate number of lobes that each lung has. So let me give you an example. So for this right primary bronchi, our right primary bronchi is going to split into three secondary bronchi. One's going to go to the superior lobe, one's going to go to the middle, and one's going to travel all the way down to the inferior. Our left primary bronchi, it's only going to have two. It's going to have one traveling to the superior lobe and one traveling to the inferior lobe. So if it comes to the quiz or exam, and I ask you, hey, how many, left or right secondary bronchi do we have? You would just count the lobes, because each lobe is going to receive a secondary bronchi. One other aspect I forgot to cover is going to be the hilum. So let's say we take a random lung, doesn't matter if it's right or left, and we're going to take a look at this from the medial view, right? So we're looking at this as if we're in the position of the heart. Our lung actually has what is known as a hilum. Now, hilum is not going to be a unique word in this class. Hilum pretty much refers to a location where everything is going to be entering or leaving an organ. So besides the pulmonary hilum, which is what's described here for the lungs, we also have a splenic hilum, and we even have a renal hilum, and we'll talk about those later on in the class. But everything that's kind of entering and leaving our lungs hilum is going to be the pulmonary artery, going to be pulmonary veins. We're going to have a primary bronchi, it's going to be entering the lungs, as well as a few nerves and lymphatics as well, but I don't emphasize that as much. Alright, talked about that, wonderful. Here's a, it's a pretty competitive image, but I still feel like mine was obviously superior, but it's okay. We'll leave it here. Oh, and then that's the hilum of the lungs. So you can see pulmonary artery, pulmonary veins, bronchus. Wonderful. Bronchi tree, sounds good. Bronchioles. Yeah, we're not gonna have to worry too much about bronchioles. It is good to know that the bronchioles are made up of smooth muscle. If you guys remember correctly from Bio 210, smooth muscle is just involuntary muscle. So it's pretty much letting us know that we don't have any control of, actively controlling the bronchioles. So this is a fairly important idea. So bronchial dilation and bronchial constriction. Bronchial is obviously referring to the bronchioles, and then dilation refers to increasing the size of the lumen. Constriction is going to refer to lessening the size of the lumen, and this is all about the body's needs at the time. Does the body need more air? Is it in a situation where it needs a lot of air, like a fight or flight response? Right, that would be our sympathetic nervous system. Our sympathetic nervous system obviously requires a lot more air, so bronchodilation would occur. For bronchial constriction, this would be more so in a parasympathetic avenue. So if we're like resting, digesting, we obviously don't need to breathe as much. What's also interesting is that allergic reactions can also cause this bronchial constriction. So that's why if you've ever seen someone having an allergic reaction, they're having a lot of trouble breathing. That's because these bronchi are actually getting constricted, like right in front of your eyes, and that's often why the treatment is going to be an EpiPen, which is going to be filled with epinephrine, which is going to be our sympathetic ANS activation, and it's actually going to cause our bronchioles to dilate because of that EpiPen. It's pretty cool. Alright, so this is what I wanted to point out for you guys for the histology aspect. So we have a terminal bronchiole, we have respiratory bronchioles, alveolar ducts, alveoli, and alveolar sacs. Now what we're looking at here is the terminal bronchiole. The reason I'm able to identify this as the terminal bronchiole is because the terminal bronchiole actually has the thickest layer of walls found all over here. So all of this is going to be the thickest layer of the wall. As soon as the wall thins out, it's going to get a little bit lower. It becomes a respiratory bronchiole. The respiratory bronchiole is going to actually be where gas exchange just starts to occur. So it's going to be a much thinner wall that's going to allow for gas exchange to start to occur. As the respiratory bronchiole travels down, we eventually become part of the alveolar duct. The alveolar duct is in contact with several alveolar sacs. Alveolar sacs are just referring to large bundles of alveoli all kind of working together. So all of these individual lines that you can see, that's all going to be our alveoli. Once again, you can see terminal bronchiole would be before predating the respiratory bronchiole, so this kind of thicker wall over here would all be terminal bronchiole. It's going to keep moving its way down. We're not going to really worry too much about parietal and visceral pleura because you guys already learned this in Bio 210, so I don't want to repeat too much information. With regard to our lungs, there's actually a pretty easy mechanism of understanding how they breathe, and that's what we're going to explain real quick. So, when we're taking a look at our lungs, there's primarily one chemistry law that kind of governs how our lungs actually contract and expand, and that's going to be based on Boyle's law. Oh my, there we go. So Boyle's law is this idea that if we have increased pressure in an environment, right? If we have increased pressure in an environment and it stays at the same temperature, then our volume is going to decrease. So we're actually going to get less volume. Whoops, let's go ahead and erase that real quick. So when we're actually going to be dealing with the lungs, let's say we have our beautiful, perfect set of lungs right here, right? Let's see, I can never get that cardiac notch right. Anyways, so this is going to be our lungs. Our lungs are sitting on top of our diaphragm, right? That's our diaphragm. Now, during inspiration, I'm going to use green to imply inspiration, so I'll put inspiration over here. Or inhalation, whatever you want to use. So during inspiration, our diaphragm is going to contract, which means that it's going to get pulled down. So our diaphragm is going to contract in a downward motion. Now, because our diaphragm has contracted downward, we're actually going to increase the volume of our thoracic cavity. And because this increased volume of the thoracic cavity, what's actually going to happen is that we're going to have this decrease or drop in pressure. Now, because this pressure has dropped, we now created kind of like a negative vacuum here, so that when this guy, right, he's just gonna open his mouth, everything's getting sucked in. All this pressure in the atmosphere, all the oxygen that's naturally in the atmosphere, it has now dropped, or it's actually above the pressure found in the thoracic cavity. So, normally our gas molecules, they want to even out, they want to keep everything like distributed properly. So these oxygen molecules are pretty much going to be forcing its way down into the lungs. During our expiration, I'll use blue for expiration. So during expiration or exhalation, whatever you want to call it, our diaphragm is going to relax and it's going to appear much higher again. So at the level of the lungs. And because the diaphragm has relaxed and it's closing off the volume, our volume is going to drop. And the pressure within our thoracic cavity is once again going to increase. So I know you guys didn't sign up for another chemistry class, but these guys are some very vital components that we want to make sure you understand with regards to how the lungs work. Now, we actually have a lot of different muscles of respiration that work with it as well. So like I said, our diaphragm is going to be involved in pretty much everything to do with quiet breathing. It's going to be doing the majority of the work. However, our external and internal intercostal muscles are also going to be helping with the work. So this is a little bit backwards, but for expiration, we're actually going to need help from the internal intercostals, and with help with inspiration, it's actually going to be from our external intercostals. So that's generally how it's going to work. I know it would have been easier if external and expiration, worked well together, but unfortunately it's just going to be the opposite. Inspiration is going to be external, expiration is going to be internal. Now, with regard to accessory muscles that are going to help in elevating the ribs, it's actually really easy to kind of notice a pattern with regards to accessory muscles. Now, if a muscle inserts onto the ribs, whether it's on the posterior side, the anterior side, doesn't matter. If it inserts onto the ribs, it can potentially assist with respiration, right? Because pulling on the ribs is actually a matter of allowing for that whole thing with Boyle's law for volume and pressure expansion to occur. So if it inserts onto the ribs, it can help. Also, the muscles that are going to be found above the diaphragm, like all of these guys here, all these muscles found above the diaphragm are going to be part of inspiration. So that's a pretty easy way to remember it. All the muscles found above the diaphragm are going to be part of inspiration. Okay, I'm just going to kind of give up because it's just kind of covering the whole thing. Whereas everything below the diaphragm is actually going to help compress the abdomen and make the diaphragm upward. So it's going to be part of our expiration. So everything above the diaphragm is inspiration, everything below the diaphragm is expiration or exhalation. All right. Now, the one thing I do want to make sure that is covered for this, we're going to kind of ignore this guy for a second. I do want to talk to you a little bit about the bicarbonate buffer system. So we're going to kind of draw out this basic formula. We're going to have CO2, right? We're going to have water, H2O. That's going to be in equilibrium with bicarbonate acid. So it's going to be H2CO3. That's also going to be in equilibrium with hydrogen ions plus H or bicarb, 3 negative. Alright, so taking a look at a formula like this, the most important thing to remember is Lachantière's principle. Lachantière's principle basically states that this entire equation wants to be at equilibrium. So if we have a lot of buildup of water and carbon dioxide, that's going to push the experiment towards the products, or it's going to push the reaction towards the products, so that we're producing more of these guys. Now, the normal pH of the human body, and I do expect you guys to know this, is going to be of not the whole body, but the pH of our blood should be 7.35 to about 7.45. Now, being in that very small range is a very tedious process that's involved for the respiratory system, your kidneys, everything to do with homeostasis. Now, let's think about what happens when we hold our breath. As we hold our breath, right, there's going to be a large buildup of CO2. And because, due to Lachantière's principle, we have a lot of reactants building up, we're actually going to come over to the right side, and we're going to notice that we're going to have more hydrogen ions forming. I hate this PowerPoint sometimes. As we build up, more carbon dioxide in the bloodstream, we're going to have more hydrogen ions kind of forming in the bloodstream. So what it's going to do is it's going to drop the pH, and it's going to make it more acidic. And we don't want that acidic environment. So that's often why we have chemoreceptors in our respiratory system that are actually going to, enable us to breathe or say, hey, we need to get this out. We need to get the CO2 out of our system. It's making our blood acidic. We don't want to be acidic. Now, the opposite can also be bad. We don't want our blood to be too basic either. If the pH rises above 7.45, that's also going to be bad. We don't want that to happen either. You might be wondering, okay, well, how might that be the case? Let's go ahead and think about somebody who is having an anxiety attack or a panic attack, and they begin to hyperventilate, right? So they're breathing out this carbon dioxide really, really fast. So this carbon dioxide is dropping, right? So because this carbon dioxide is dropping, they're no longer getting enough carbon dioxide, so the hydrogen ions are also dropping. You might be thinking, okay, well, we don't really want those hydrogen ions. Well, we kind of do in a way, so we want to be able to maintain this balance. Now, because we're breathing out too fast, this person's having a panic attack, they're breathing out carbon dioxide too fast, their blood is actually getting more alkaline or more basic, and we don't want that to happen either. So what you can often do as a treatment, you give them a paper bag, right? The reason why this paper bag works is because when they start breathing in all this carbon dioxide again, their pH blood regulation is going to go back to this zone because it's going to get a little bit more acidic, but that acidity is going to bounce us back into the perfect 7.35 to 7.45 range. Now, one more thing I want to talk about is just the presence of pneumocytes. See if I can spell this out right. Pneumocyte 1 and a pneumocyte 2. So I just want to make sure you guys are aware of what pneumocytes 1 and 2 are. So if we break up the word pneumo refers to lung, cyte refers to cell. So we have a pneumocyte or a lung cell. So we have type 1 and type 2. The type 1 is going to be made up of our simple squamous histology. And these are going to be the actual alveoli. So the actual alveoli that are allowing for this gas exchange to occur, these are going to be known as our pneumocyte type 1s. Our pneumocyte type 2s, this is actually going to be simple cuboidal. And hopefully you remember from Bio 210 that simple cuboidal is often really good at secreting and absorption. What simple cuboidal is going to be secreting from our pneumocyte type 2 is actually going to be a substance that's very important known as surfactant. Alright, now within our pleural cavity, we have what exists a lot of water. And what water likes to do, water molecules like to bond to each other, right? So they like to kind of make this polar bond with one another, this hydrogen bonding. And that's, a natural state of water, but it's not good for our lungs because this building of polar bonds, these hydrogen bonds between the water molecules, this will actually create a lot of surface tension. And if the surface tension is going to be too high on our lungs are not going to be able to expand and breathe. Our lungs are not going to be able to expand outward, and they need to be able to do that. So this is where our pneumocytes 2 come in. We have this surfactant. This surfactant is going to break up those hydrogen bonds and make sure that that surface tension on the lungs is not as high as it wants to be. So surfactant is going to allow us to make sure that our breathing is smooth and easy and there's no surface tension building up on our lungs. Alright, but that is pretty much the entirety of the video. I hope you guys enjoyed that.